Today we have with us Professor Carsten Schoch, who is a renowned cardiologist in Berlin. Along with him, we have Dr. Ajay Naik and Dr. Vineet Sankla, who are the interventional cardiologists and cardiac electrophysiologists at SIMS Hospital, Ahmedabad. The doctors will be talking on the significance of cardiac remodeling in heart failure and the optimization of heart failure patients' pathways. Thank you everyone for joining us today. We will now proceed towards the videos, please.
So that's interesting to go to the next talk. What I have not told you directly in the last 10 minutes is that heart failure never can be healed. We try to treat that, but heart failure itself will be imminent progressive disease. It's like cancer. Most of the cancers you also cannot heal. And that is the way how heart failure works. You see on the axis the function of the cardiac and renal function. You are born, everything is fine. Here you're doing the first mistake. You decided to smoke. You get an myocardial infarction, left ventricular function. This is here, the red curve is, of course, depressed. You're lucky, you come to a nice, good hospital. They stabilize you. And over the time, even with an ACE inhibitor, but also with Weimar, you will get a further progression of the disease, like my NYHA2 class 2 patients. Suddenly, BNP levels starting to rise. And then the next decompensation comes, the next decompensation comes. So no drug, no treatment is developed until today, and I don't know whether I get the age to see whether stem cells can make that at the end, that these can be completely prevented. The thing and the task of us cardiologists is to slower the speed of the curve and to prevent these deaths. What were the mechanisms we had developed in the medical school, for instance? The idea of heart failure in the 60s and 70s was a cardiorenal syndrome. They saw cardiac was not pumping, kidney was not producing urine, so they gave diuretics and digitalis. They wanted to improve renal perfusion. Good, that was the treatment at that time. But what was the effect? Look at that. At that time, where diuretics and digitalis were the only drugs available in the hand from cardiologists, in the survival rate, nothing happened. That is not what I say. Diuretics are cosmetics, good to improve the symptoms, but they have no effect on the prognosis. Then, in the 70s to 80s, the heart failure model changed. We came up to the hemodynamic scenario. We came up with afterload reduction. And short before we really could show that this is better than this former cardiorenal model, the neurohumoral inhibitor model came with ACE inhibitors, 81 blockers, and mineralocorticoid receptors. That came in the 80s and the 90s. And that was then the time where the first time cardiologists had a drug in their hand that the patient could live longer. Until the 90s, 92, we just gave drugs for or against the symptoms. So what was here the cool thing? Why suddenly mortality improved? The cool thing was that we improved remodeling. We were able to smallerize or to prevent the further progress of dilatation of the left ventricle, measured here in left ventricular and diastolic volume. We could see that even a small increase of 10 milliliters increased death or hospitalization up to 9%. Similar for left ventricular and systolic volume, hospitalization up to 15%. And every time when you had a patient where ejection fraction and these remodeling was improved or not so strong, and if you take not only the left ventricle but also the atrium with you in the calculation, then suddenly the patient had a benefit in the prognosis. So the clue that we had in the 80s with the ACE inhibitors, drugs in our hands, that the patient lived longer, was based on the mode of action of these drugs, that they were able to induce a so-called reverse remodeling. You see that here, that is the reason that nearly all patients, that is a must, have an ACE inhibitor, beta blocker, aldosterone antagonist on board. These are the 3 drugs who really show that a reverse remodeling is possible. Ivabradine, not so clear. Digitalis, no data. Diuretics, no data. With the CRT system, we have also in reverse remodeling. And now Weimar came. And you know this trial, the paradigm trial, and showed you that with Weimar you have even a better progress for the prognosis than an ACE inhibitor, which was the kid in the block in the 90s. You get an additional risk reduction up to 20%, or you see that here in top what Weimar can do with an ACE inhibitor or compared to an AT1 receptor antagonist. And that led to all guidelines that ARNI is the preferential to use drug. Now, why does that happen? How Weimar is so effective? What is the mode of action? Until yet, it is not clear. In the paradigm trial, no data for ejection fraction until today had been shown. We just know they live longer, they have a better quality of life. But why? What is the mechanism? Is there something new what we don't know? Or is just the reverse remodeling here more potent of that what we have until today? And that had been investigated in a trial. Now, let me see, this is here not fine. When we think about reverse remodeling, we can think about very good drugs, the disease itself, whether there's fibrosis on board or not. And only when you have drugs which can deal with these, let's say, side effects or cofactors, you will have an adverse remodeling, and that can be most probably also shown by BNP levels as a surrogate parameter under these conditions. However, what's really going on? Why we have these beneficial effect until Weimar? There are now 2 trials. These are not trials to explain no additional clinical data. These trials are mode of action data. We would like to understand what is the mechanism here behind. And one is the so-called EVALUATE trial. The EVALUATE trial is a small trial with about 500 patients. They got an ACE inhibitor, enalapril or Weimar, and the patient had been investigated for only 12 months. That is short, isn't it? When you would like to see whether a reverse remodeling is detectable, would you come up with a 12-month approach? Usually I would say, half a year or a year, something like that. That is what I would say. But they had here the courage to say, we check what kind of remodelings we would see already after 12 months. And what they have investigated is something interesting. They have investigated the aortic stiffness. The aortic stiffness is important because it's analyzing the afterload quality. And for that, you see here the central flow Doppler curves and the central pressure waveforms. It is possible to analyze how the aortic stiffness works. So the question was, is just due to afterload reduction the effect of Weimar explainable? Or is really something happened in the myocard itself? And that was the secondary endpoint here. Therefore, they investigated natriuretic peptides and the left ventricular anti-systolic and systolic volumes, as well as from the LA, as I have told you, that these are the most important remodeling markers we have under these conditions. And that is what you can see here. Officially, the trial is negative because the primary endpoint was the question of whether the aortic stiffness was significantly improved. And as you can see here, it was not. So all the benefits, which I will show you on the next 2 slides, are not benefits due to a vasodilatation or a compliance change in the vessel. That can come later. But after 12 months, that had not been changed. So despite that not the afterload or the stiffness of the vessels were changed, you have this result. The volumes become smaller in the diastole as well and the systole as well in the atrium. Already after 12 months, so fast. And the patients were not treated against placebo. They were treated against enalapril. An enormous effect. And this also can be then further, at least in this early phases, translated in a benefit for the diastolic function of these conditions. What says the patient? The patient itself recognizes that. When the volumes of the ventricle stays smaller, ejection fraction more stabilized, diastolic function, filling pressure lower, then of course it is more easy to walk to the steps. And you see already after 2 walks, 12 weeks, a highly significant improvement under these conditions. That's one trial, what I want to show you, which is a mode of action trial. After 12 months already seen that the wall stress of the left ventricle had been significantly reduced, better than that what had been reduced with an ACE inhibitor. What shows that the PROOF trial, the PROOF-HF trial, is also a small trial, which would like to see how changes in natriuretic peptide levels, which we expect, we know from Weimar, can be also translated to parameters for the remodeling markers. Small trial, ejection fraction lower than 40%. Weimar was the only drug which had been investigated. And here we looked for 6 months and 12 months. So really longer process under these conditions, but no ACE inhibitor was a comparator available. What you see here is that what was expected if you reduce afterload and treat a sick heart with a drug like Weimar, natriuretic peptides will fall. And you see how fast that works. You see that here from 816 to nearly the half in about 12 months. In our case, we also saw that already after 3 to 4 months, nearly the half of BNP levels had been reached. And the fall of natriuretic peptides was associated highly significantly with an increase in ejection fraction and the changes in these remodeling parameters with respect to the volume of the left ventricle and systole and diastole as well as the left atrium. And that you see here, an increase in ejection fraction up to 9%. And a downgrade of the end diastolic volumina between up to 12 to 15 millimeter per quadrat meters. Here, sometimes some of the patients had even a higher increase of ejection fraction, 1/4 up to 13%. And with respect to the LAVI and to E2E prime, the diastolic function, it was also highly significant as a right consequence for that. And as was that we have learned before, reverse remodeling is also translated in an improvement of quality of life. So whenever you can see here, when BNP levels are falling, it is a direct correlation to an improvement of the remodeling in the reduction or the prevention of the dilatation of the trials. In this trial, some of the patients had been already pre-treated with an ACE inhibitor. Some of them were naive, so they got the drug immediately. And every time you see the same fall in BNP was translated with a reduction in the form of the remodeling under these conditions. So I wanted to stop here my talk, but I see that that was not the right version, but that is not so complicated. Anyway, we have already a long day with us here together. So I want to say that heart failure is never stable. 50% of patients with heart failure are dead after 5 years. When they have NYHA class 2, it does not mean automatically that they are stable. Mild symptoms does not mean that you have a mild disease. Nobody speaks about mild breast cancer, right? Nobody should speak about a mild heart failure when ejection fraction is lower than 40%. And remodeling, best remodeling, complete remodeling, not only left ventricle, but also the atrium. That is that what we can say that Weimar is in the club of those drugs who are really able to induce and reverse remodeling, but is just the best in the class because it is extremely effective. And when we have side effects, what we have discussed during the case scenarios, mostly it has something to do with the blood pressure. We have also tools that the patient can keep the drug. It's not my first time in India. Every time I have here my pleasure and meet my friends. And I told that my daughter, and therefore she said, okay, puppy, if you stay with me in the birthday and give me my watch, which I wish to have, you can leave. So that is the reason that we're here. And the talk, and is also very important. We speak about heart failure. I think this is the killer number one worldwide. If you go to a cancer meeting, they will tell you that cancer is the killer number one. If you go to the meeting where only nephrologists, they will tell you kidney disease is the killer number one. Believe me, heart failure is the only killer number one. And I have to say, I'm not proud about that. The reason here is that heart failure never can be treated. It is never stable. Look at that. We have seen that cartoon. Just to make clear what's going on here, you're born with a normal kidney and renal function. Everything is fine. Here you made your first mistake. You started to smoke. You got a myocardial infarction. Ejection fraction is low, but you're a lucky heart failure patient stabilize you. They bring you back into the city, and probably the patient does not feel with complaints in his daily problem, but ejection fraction and cardiac function, of course, is not as it was in the beginning. And then over the time, and this is the history of the disease, the next progression of the disease, probably the next decompensation will come, and there are no drugs available which can prevent that. Therefore, heart failure is never stable. If you have a heart failure patient in front of you, you have to whole time think about what can be done to reduce, not to stop, to reduce the progression of the disease, to have a curve like that. And what we are doing here, yes, we have specific drugs in our hands, ACE inhibitors, ARBs, beta blockers, aldosterone antagonists, diuretics for the symptoms. Then we're doing a good thing, but it is limited. Look at that. I was really surprised and astonished as I saw that. If you have a heart failure patient with reduced ejection fraction, you do not give anything of these classical drugs. The patient has a mean rate to expect to live longer, 1 year. If you give an ACE inhibitor, you get 8 months. If you combine that with a beta blocker, you get probably an additional year, and aldosterone antagonist probably 3 years. So we celebrate that we have a relative risk reduction of about 30%. But that is, of course, not enough. I was speaking with my wife, and she comes home and I tell her that I have cleaned up the kitchen up to 30%. She's not happy with me. So we have still to do something, and especially when we see that the next step of the progression of the disease is reached. The guidelines here, allow me to show me the European ones, this is my home country, said you have to do something more. Think about ivabradine, think about devices. But this is the most important thing. Think about when is the right time point that the ACE inhibitor is not anymore good enough and should be exchanged against an ARNI, against Weimar. And that it is because we had these fantastic trials showing you that if you have a patient with reduced ejection fraction, you had the classical triple therapy, which I just had celebrated with you. You give instead Weimar, you have an additional risk reduction of about 20%. And if you want to know what that means, it shows you here. That is what you get if you have the classical triple therapy, ACE inhibitor, beta blocker, mineralocorticoid receptor antagonist. But if you do a simple switch from an ACE inhibitor to an ARNI, you get that on top. What does that mean for the patient? Estimated and calculated about a scenario of 10 years. These difference, which you see here on the slide, means 2 years longer living. 2 years. And that is the point that worldwide, nearly all heart failure scenarios and guidelines recommend to give an ARNI when, despite an ACE inhibitor, you have a progression of the disease. We can discuss that later, what that means. This is the so-called replacement strategy. And also in the States and also in other countries, like in your country, there is the instead scenario. Even in a severe heart failure patient, do not test an ACE inhibitor. We know that the ARNI is better, and therefore you also can start with that, more or less. in the beginning. So, and now it comes. This is the old story, and everybody believes, yes, okay, fine. When I have a heart failure patient, suddenly new heart 3, new heart 4, something is not going right, then I think about to give Weimar. That's wrong. Who had been treated in the trial? The paradigm trial I have shown you. 70% of the patients had NUHA class 2. It was not the clinical scenario where you are thinking about a heart surgeon, transplantation, and so on and so on. NUHA class 2, that was more or less relatively stable patients. I'm coming from the university. I do not see usually these patients. In my hospital, they are the decompensated patient. They are more or less dancing around the intensive care unit. But in the paradigm trial, patient had been investigated, and you could see that you can easily increase the prognosis up to 2 years in patients who are not really suffering. When is the patient suffering with NUHA class 2? Usually they are not suffering. Yes, they are not anymore feeling so young than they feel before, because they also found strategies in their daily routine to overcome the cardiac limitation. So usually the general practitioners, the not university not university cardiologists see these patients. And that is what is so important. NUHA class 2 does not mean that the patient is stable. As I told you, heart failure is never stable. And in these patients, where the patient even is not complaining, the trial has shown what you can do for this patient. So what does that mean for the clinical routine? That's clear, 2020. All heart failure patients need an ACE inhibitor and beta blocker and mineralocorticoid receptor antagonist as soon as the ejection fraction is reduced and kidney and potassium and blood pressure function allows that. And if this is a NUHA class 3 to 4 patient, I think it is clear everybody, even a non-cardiologist, will accept something is here wrong, and he will switch from an ACE inhibitor to Weimar. But the NUHA class 2 scenario, that is really difficult. And I would like to call NUHA class 2 patient with signs of the progression of the disease. These are the patients who we have to identify. They are not in the hospital. They are not really complaining. These are those patients which are not easy to detect, but they are a danger. And I think we need in the clinic specific parameters, serum biomarkers, hemodynamic markers, psychosocial factors, or clinical markers. And if some of them pop up, and I've summarized them here on my slide, quality of life, comorbidities, kidney dysfunction, BNP is rising, or the most easiest case, the patient is again decompensated despite an ACE inhibitor. Then even the patient is officially NUHA class 2, but you have these red flags popped up. I believe this is a Weimar patient, and then you have to switch from an ACE inhibitor to Weimar under these conditions. So the question is, if this drug is really so potent, when is the right time point to start? Shall we wait until the next decompensation is there? Shall we use it only in the stable phases, because that was even the NUHA class 2 phase and the so-called plateau phase, what had been shown in the trial? Or when the drug is really so promising, why not also starting here, or even here when the patient has been just recompensated, not to lose some time? I think this is an extremely important question. So what about when we have patient in danger, to start with the treatment already in the hospital, not only outside when the patient is by the general practitioner and then you do some routine tests and you have a good day and you think about to improve the scenario for the patient. That is important, because this phase here, when the patient had been decompensated, you recompensate them in the hospital, then you prepare the patient for the outside scenario. This is a so-called transition phase, is extremely dangerous. And as I saw this slide the first time, I really was surprised to see when the patient is in the plateau phase, the patient is very long stable. At the end, he comes to the end stage phase. Okay, he will die. But in the transition phase, exactly the phase when the patient is in the hospital, he has seen us. And then he is translated to the general practitioners. There we are losing patients. Why? Naja, because the patient is exchanged of the hospital not completely properly prepared. Why? Patient has to leave the hospital. He was already too long in the hospital. The price pressure comes here. The blood pressure is not still ready. We need more time. The doctor outside shall do that. Then the patient gets an appointment by the doctor outside. He says, I will not change something. The patient just comes from the hospital. They know why the dose is so low. And low means bad prognosis of the patient. You see that here. Especially in the transition phase, we are losing heart failure patients. And that is so sad because the patient has just left the hospital. And even in then, when the patient had been decompensated, usually the doctors just give diuretics because they say, yeah, decompensation is a volume overload. We just give diuretics. But diuretics are cosmetics. They do nothing with respect to the progression of the disease. They, of course, reduce the overload, but they are not fighting against the progression of the disease. So the question here is, when is the best time point to start to overcome the risk of the transition phase? And we all heard about side effects from Weimar-Dar, hypotension, kidney function, and so on and so on. Therefore, the doctors have the idea to start late and slowly. And in the transition trial, now you know why the name of the trial has transition time, had been shown that it is relatively easy. Up to 50% of the patient can be already treated with the highest dose of Weimar-Dar in the hospital when the patient had been decompensated, left the ICU, he is recompensated, does not need any catecholamines anymore or IV diuretics to leave the patients outside properly prepared in the transition phase with high doses of Weimar-Dar. You see that here, especially those patients who had not been in heart failure prior, good rhythm, are those patients who accepted that. 50%. That is a norm. The other 60% had at least half of the doses. So I believe we have to treat the patients already in the hospital to prepare them to overcome the transition phase for this scenario. And what does that mean for the patients? The TRISN trial just showed you that it is relatively safe. In the Pioneer trial, a smaller trial, placebo-controlled trial, not in registry, shows you that you have a high chance that even the outcome is improved. And you see that here, number you need to treat is 13. You just have to transition to exchange 13 patients properly with relatively high doses of Weimar-Dar already starting the treatment in the hospital to prevent such an event. And therefore, I come to my end, dear colleagues. I would like to say, treat early. Heart failure is never stable. If you treat here, the point of no return is, of course, every time here, and the win is short. If you treat already here in NYHA class 2 and or in the hospital, then you're doing the best for the patient. That is that. But also my little daughter would say the triple therapy with an ARDI is the best in stable heart failure. NYHA class 2 does not mean that the patient is stable. He has heart failure. Nobody speaks about stable breast cancer. Heart failure is never stable. And therefore, mild symptoms does not mean that you have a mild disease. And an ARNI in the clinic transition phase is safe, and we should use this in our patient as fast and as early than possible. Thank you very much for your attention.
Thank you everyone for joining us today in this insightful webinar. Our doctors are busy in a surgery and will get back to you with the answers to your questions. Thank you everyone.